Hello everyone, I'm Dr. Lahari here from Department of Oral Medicine and Radiology. This is a lecture on non-neoplastic disorders of salivary glands. The learning outcomes would be to classify non-neoplastic salivary gland disorders, explain etiology, clinical and histopathological features of mucocele, SIALADENITIS, mumps, bacterial SIALADENITIS, SIALADENOSIS, also called as SIALOSIS, SIALOLITHIASIS, Sjogren's syndrome, and necrotizing SIALOMETAPLASIA. So let's just revise the anatomy of the salivary glands. We have three pairs of major salivary glands and numerous minor salivary glands. So the image that you can see here shows us the parotid gland location as well as the sublingual gland and the submaxillary, also called as a submandibular salivary gland. Now, apart from that, we have minor salivary glands that are distributed all over the oral mucosa, and these are ductless glands, and they're either serous, mucous, or mixed type of salivary glands. If you were to look at the classification of disorders of salivary glands, they can be divided based on their etiology into autoimmune conditions like Sjogren's syndrome or chronic graft versus host disease leading to disorders. Developmental disorders such as salivary gland aplasia, congenital fistulas in the duct system, or a staphylosis, which we will see in the upcoming slides. Iatrogenic causes like radiation, post-surgical disorders of salivary gland, or a Botox injection leading to damage to the salivary glands. Inflammatory causes of diseases like Ig4 related diseases, also known as Kuttner's tumor or a Mucocele disease. Infections causing infection of the gland due to viral conditions like cytomegalovirus, HIV, hepatitis C, or bacterial causing, for example, granulomatous diseases like tuberculosis affecting the salivary glands. Medication induced or medication associated disorders of the salivary gland caused by xerogenic drugs, neoplastic, benign and malignant tumors of the salivary glands, non-neoplastic conditions like SIALOLITHIASIS, which are also obstructive disorders of the salivary gland, and systemic conditions like anorexia nervosa, diabetes mellitus, chronic alcoholism, or sarcoidosis that affect the salivary glands. Now we will look at some of the examples more commonly occurring diseases in this chapter. Let's look at the most common obstructive disease, SIALOLITHIASIS. SIALOLITHIASIS means formation of stone in the salivary ducts. The contributing factors to what happens and why there is stone formation is primarily because of pooling of saliva, which leads to stone formation. So, generally, if there is inflammation or irregularities in the ductal system, or there are local irritants, or patient is on anticholinergic drugs, or a combination of all of these factors contributes to the pooling of saliva and stone formation. Generally, a salivary stone or a sialolith, as it is called, has a composition of hydroxyapatite crystals, calcium phosphate, magnesium, and potassium, as well as chloride and ammonium ions. So, in patients with gout, the stones are generally made of uric acid. The most common location for a sialolith is the submandibular salivary duct in around 80 to 90% of the cases, followed by the parotid or the sublingual salivary gland ducts. The higher rate of sialolith formation in the submandibular salivary gland and its duct is primarily because of the tortuous course of the Warthin's duct. We understand that the location of the and the course of the Warthin's duct are responsible of stasis of saliva. Also, the higher content of calcium and phosphate levels in the saliva produced by the salivary gland, and the position of the submandibular salivary gland itself, which is lower than its orifice of the duct, and hence there is a tendency for stasis of saliva within the gland and the duct itself, making it one of the most common salivary glands to have silolith formation. This is an image which shows you the location of the submandibular salivary gland. It's interesting to note that it is a J-shaped gland, part of which is located below the mylohyoid muscle and part of the gland is located above the mylohyoid muscle. So you can understand based on the anatomy and the location of the Wharton's duct that it actually has to pump its saliva and pour it against gravity higher up into the oral cavity. And hence there's a tendency for pooling of saliva in the lower part of the gland, making it a common location for stone formation. This is a picture which shows you a stone formation in the proximal part of the salivary gland duct. These are examples of how stones can look like. And this is a radiographic image of one of my cases which I had seen as a postgraduate, where you would, on a submandibular, on a occlusal view where the duct, the proximal part of the duct and its the siloliths within the ducts are visible very clearly because of their radiopaque content. Now, it's important to understand that not all siloliths are crystalline or calcified enough to be visible on the radiograph as calcified structures. Sometimes the calcification process is not complete enough, and yet the silolith blocks the duct and blocking the release of saliva. Yet on the radiograph, you may not see the image of radio opaque silolith. But in this case, you can see in the occlusal radiograph that there are two siloliths in the salivary duct. Obviously, the duct is not visible because it is a soft tissue structure. So, when you're talking about diagnosis and treatment of siloliths, the clinical features of a patient would be acute, painful, intermittent swelling of the salivary gland due to obstruction and secondary infection. What happens is during eating, there is increased salivation. So, there is swelling of the gland because there is an obstruction and saliva cannot flow freely into the oral cavity. Bidigital palpation of the gland and the duct must be performed, and when it is done, sometimes the silolith can be easily diagnosed and its location can be made out clinically. On radiographs, like I just discussed, poorly calcified stones are not visible. So, plain radiography of a submandibular salivary gland in an occlusal view, or a parotid gland on an anterior posterior view, or a puff cheek posterior anterior view can show calcified stones, and they can be used. But to see them more clearly, a CT scan may be required, or siloendoscopy can be done, which is an endoscopic unit with a surgical tip that can help biopsy the gland or the duct, as well as remove the calcified material under local anesthesia within the ductal system itself. So this is an example of a siloendoscope which has a thin needle, and once a silolith is located, it can be identified by imaging, and the silolith can be actually broken down into pieces or removed with the help of a siloendoscopy, also SIALOLITHIASIS. Next, let's move on to mucocele, which is an extravasation phenomenon and caused by trauma of the minor salivary glands. Now, it's very important to remember the common location for a mucocele is a lower lip, as shown in the images here. And this happens due to trauma, often because of biting of the area, and the salivary gland gets crushed, and these are the minor salivary glands, and you must remember that the minor salivary glands do not have ducts. This is an example of a superficial mucocele. We often have these tiny mucoceles cropping up in the oral cavity, especially on the palate, when there is minor trauma, such as toothbrush related trauma, or even when you're eating sharp foods like chips or crisps, which can actually locally traumatize the mucosa, and the minor salivary gland actually gets traumatized, and there is extravasation of saliva into the adjacent mucosa, leading to a superficial mucocele. Often superficial mucoceles rupture on their own and they subside. Another variant is a ranula, which is generally larger in size and seen in the floor of the mouth. And this is an example of a case with a plunging ranula, really large, leading to a large appearing swelling in the neck. So, when you're talking about treatment of mucocele and ranula, generally for mucocele, surgical excision is advised, followed by biopsy of the excised specimen, and this is done to prevent recurrence. So what happens is that the entire salivary gland, generally a minor salivary gland, and its surrounding areas are excised to avoid or prevent recurrence. Intralesional steroids have been tried, but their success is limited. In case of a ranula, surgical intervention is sort of, and also marsupialization and sublingual gland excision have also been suggested as treatment plans. Intralesional steroids have also been tried. Now, if you remember, the term ranula is actually derived from that of a frog's belly, because it looks like a frog's belly, and it's big, and it can sometimes enlarge at meal times and appear like a large swelling in the neck region. Moving on to necrotizing silometaplasia, this is a benign self-limiting reactive inflammatory lesion of salivary gland tissue origin. Again, the minor salivary glands are affected, and it can appear like and can be confused for either a leukoplakic lesion or sometimes even a malignancy. But this is self-limiting and generally subsides within a period of 2 to 3 weeks. Next, moving on to sialadenitis. The inflammation of the salivary gland is called as sialadenitis. There are various causes of inflammation. It could happen because of allergic reactions, allergy such as drugs or pharmaceutical agents causing irritation to the gland and causing inflammation of the gland. Viral conditions, which are like mumps caused by paramyxovirus, cytomegalovirus, HIV, or hepatitis B. Bacterial infections, which could be the acute or chronic sialadenitis, that is caused by aerobes such as Staphylococcus aureus, uh, Staphylococcus viridans, Haemophilus, or E. coli, and anaerobes like Prevotella, Porphyromonas, or Fusobacterium. Chronic sclerosing sialadenitis is a condition which is also called as Kuttner's tumor. Generally, sialadenitis can be painful if it is especially associated with bacterial or viral origin, and the person will exhibit fever. This is an example of a child with mumps, as you can see, is a common condition where the parotid is involved with paramyxovirus infection. Now, on the other hand, the pus discharge that is seen is generally classical of bacterial infection or bacterial sialadenitis, and if it is parotitis, that is the parotid gland is involved because of bacterial infection, then you can see pus discharge from the ductal system, and this is an example of pus discharge from the Stenson's duct. In the classification of salivary gland disorders, we've come to developmental disorders. One of the example is a Staphnase bone cavity. This is an appearance seen on the panoramic radiograph and could be an incidental finding. This should not be confused for a cyst, and it is not a true cyst. It is just a corticated defect in the posterior mandible below the inferior alveolar canal, and it may contain an extra part of the submandibular salivary gland. So no treatment is offered, and generally the patient is made aware of the condition, and it is left alone. Moving on to radiation-induced pathology, head and neck cancers and radiation therapy in the head and neck region induces salivary gland destruction. A majority of the time, there is invariable involvement of the salivary gland, and radiation causes destruction of the salivary acini, leading to xerostomia, and the patient experiences viscous saliva. There is accompanying mucositis as well. And generally, absent salivary gland function, total absence, can happen after 6 to 7 weeks of radiation therapy, and permanent damage can occur at radiation amounts of 24 to 26 grays. Also, the patient could be accompanied by radiation caries. This is because of hyposalivation or the lack of saliva in the oral cavity. Um, Radiation induced salivary gland destruction can also increase the incidence of salivary gland neoplasms in these patients. So, it's important to prevent the damage caused by salivary gland destruction. It's important to actually use the 3D conformal CT scans with also radioprotective agents like emifostine, which can prevent the amount of damage that happens to the salivary glands during radiation therapy to the head and neck region. Like I told you, some amount of radiation invariably reaches the salivary gland due to the proximity of the cancer, depending on the proximity of the cancer and the area that is irradiated. But nevertheless, the gland can regenerate, and radioprotective agents like drugs like emifostine can help in a recovery of the gland and saving at least part of the gland for the patient. Systemic conditions with salivary gland involvement are numerous, but it's important to highlight the most important ones, that is diabetes mellitus, anorexia or bulimia, chronic alcoholism, dehydration, medication induced dysfunction, Mikulitz disease, Sjogren's syndrome, and granulomatous conditions like tuberculosis or sarcoidosis. I will not be going to the details of each and every disease, but just looking at some of the most important ones. So, when we're talking about salivary gland diseases, the most important disease that has to be mentioned is Sjogren's syndrome. This is a chronic autoimmune disease with oral and ocular dryness. Generally, there is exocrine dysfunction and destruction of the exocrine glands. Also, there is lymphocytic infiltration because it's an autoimmune condition. So, the etiology of Sjogren's syndrome is actually unknown and there is no cure that is found. So, Sjogren's syndrome can be classified as primary Sjogren's or secondary Sjogren's. Primary Sjogren's, there is lacrimal and salivary gland dysfunction and not really an autoimmune condition per se. Whereas in secondary Sjogren's syndrome, there is lacrimal gland, salivary gland dysfunction with an additional connective tissue disorder autoimmune condition like SLE, rheumatoid arthritis, scleroderma, or primary biliary cirrhosis in combination with the existing lacrimal and salivary gland dysfunction. So this is an example of a patient who has bilateral enlarged salivary glands, especially the parotid glands, prominently enlarged as a result of SIALADENITIS that is seen in Sjogren's syndrome. Also, there is dryness of the oral mucosa and the tongue appears really dry and red. And this is a test to check the amount of tear ducts, the amount of tear produced or lacrimal gland function to assess the amount of tears that are produced. So, the most important or the most famous example that comes to mind when we're talking about Sjogren's syndrome in the recent years is Venus Williams, the famous tennis player. At the age of 31, she had to withdraw from major competition because she was diagnosed with autoimmune disorders, which caused her um, fatigue and joint pains, and which could have led to larger long-term problems. But she fought back and won the championship in the next couple of years to come, and was able to keep the disease in check. Like I told you, it's not possible to entirely cure the disease, but symptomatically manage it and keep it under control. It's important to remember that it's actually an autoimmune condition. The diagnostic criteria for diagnosing Sjogren's syndrome, the patient must exhibit four of the six mentioned criteria. A labial minor salivary gland biopsies, when done, should be positive for diagnostic or positive or diagnostic of Sjogren's syndrome, and that's one of the best diagnostic criteria. Presence of autoantibodies against anti-SSA or anti-Sjogren's syndrome A and anti-Sjogren's syndrome B. Ocular dryness, presence of oral dryness, reduction in lacrimal function measure, Salivary function and quality also are reduced, and imaging through silography, CT scan, or MRI showing classical features of or diagnostic features of Sjogren's syndrome. On silography, imaging of the salivary gland done with the help of a retrograde dye injection into the salivary duct. The classical image that is seen in cases of Sjogren's syndrome is a branchless, fruit-laden tree appearance or a cherry blossom appearance. Now, this is a very important clinical or radiographic features that is important to remember and associated with Sjogren's. This happens because of stasis of the dye within the salivary parenchyma, and not enough salivary production to actually eliminate the dye. So this indicates that there is stasis of the dye within the salivary parenchyma, and an indication of sialactasis and Sjogren's syndrome. So similar appearance seen on the CT scan as well, which shows you these radio opaque or opacified areas of stasis of the dye, and which is called as sialactasis, classical feature of Sjogren's syndrome. The treatment of Sjogren's syndrome relies on symptomatic relief and also disease modifying drugs, generally steroids, that is glucocorticoids, immune suppressants, antimalarials, and biological agents like tumor necrosis factor or interferon alpha have been used to help with the disease. And the treatment of xerostomia is also important, done with the help of artificial saliva, oral rinses, and water sipping. Stem cell replacement therapy has been tried for salivary hyperfunction, and it should be noted that there is increased incidence of malignant lymphoma in Sjogren's syndrome, and hence these patients need to be under regular follow-up. So, when it comes to the diagnostic workup in a patient with salivary gland diseases, the clinical examination is of utmost importance, as the most common presentation seen is dry mouth. So, patients who are having any form of salivary gland disease might first present with the dry mouth. Also, it's important to understand that saliva collection and its analysis, the process of analysis is called as xylochemistry. Salivary gland imaging and salivary gland biopsy are all parts of the diagnostic workup. Let's look at xerostomia. The subjective report of oral dryness is termed as xerostomia. It is a symptom and not a diagnosis or disease. So that is something very important to remember, that when you are seeing a patient who is having dryness of the oral cavity, the symptom is called as xerostomia and is not essentially a diagnosis. So the causes of xerostomia could be salivary causes or non-salivary causes. The salivary causes could be salivary gland dysfunction caused by drugs which reduce the salivary flow, also called as xerogenic drugs, tumors, or radiotherapy itself. Other examples of xerogenic medication could be antidepressants, anticholinergics, antispasmodics, antihistamines, antihypertensive sedatives, diuretics, bronchodilators, and others like caffeine, alcohol, and cigarette smoking. Non-salivary causes of xerostomia are dehydration, central cognitive alterations, oral sensory disturbances, psychological conditions like depression and anxiety. So it's important to understand here that the salivary causes are more common than the non-salivary causes of xerostomia. So if a patient comes to you reporting with oral dryness, it's important to rule out the salivary causes followed by the non-salivary causes. So clinical features of patient with xerostomia could be candidiasis, fungal overgrowth, generally the erythematous type, because of lack of enzymatic action and the antibacterial, antimicrobial activity of the saliva itself. Also, there could be atrophic areas on the tongue, angular cheilitis, which happens due to dryness of the oral cavity and red areas in the corner of the mouth. Lipstick sign and tongue blade sign, we'll look at these in the pictures that are going to be shown in the next slide. And enlargement of salivary glands, which can be seen by bimanual palpation. What we mean by bimanual palpation is using two fingers or digits, index fingers from two different hands to palpate the salivary gland, both intraorally as well as extraorally at the same time. Upon palpation, it's important to note whether the glands are tender. Is the salivary content viscous and scanty? And is the exudate or the saliva that comes off from the duct, is it cloudy, which would indicate bacterial infection? So this is an example of a person with a dry tongue and angular cheilitis, where the tongue appears very dry and erythematous, and the angles of the mouth are appearing raw and eroded, and this is called as angular cheilitis. The other effects of salivary gland or hyposalivation or xerostomia would be high caries index. We are aware that saliva is a very important component in maintaining homeostasis or the balance in the oral cavity. And when there is less saliva, there is increased bacterial count and there is no cleansing action of saliva, which leads to high caries index. Identification of dry mouth can be done by, in case if the patient is wearing lipstick, then you would see that the lipstick sticks to the maxillary anterior teeth, which is a very classical sign of no cleansing action of saliva being present. On the other hand, the tongue blade sign refers to when the mouth mirror gets stuck to the buccal mucosa during examination, and because of lack of saliva, the mouth mirror doesn't slide in the oral cavity. And this sign is called as a tongue blade sign because generally tongue blades or the wooden blade was used for examination of oral cavity. Moving on to saliva collection. Saliva can be collected from major salivary glands, which could be in the form of whole saliva, which is done by draining, suction, spitting, or using absorbent sponges. This whole saliva could be either stimulated or unstimulated. Now, when we talk about stimulated, it means stimulated with the help of an inert substance like paraffin wax. Unstimulated is when you are not having excessive flow because of object inside the oral cavity. So various collectors have been designed and used for collecting saliva from the duct of a salivary gland. So in the oral cavity, generally all the saliva that is there is a mixture of the submandibular, sublingual and parotid glands. So if you were to specifically collect from the parotid itself and analyze the parotid saliva, then there's a special collector called as the Carlson-Crittenden collector, which can be clipped on to the Stenson's duct to collect parotid salivary gland secretions. The similar one used for collecting saliva from submandibular and sublingual glands is called as a segregator. So to identify whether the patient is having hyposalivation, the unstimulated whole salivary flow rate lesser than 0.1 ml per minute or stimulated whole salivary flow rate lesser than 0.7 ml per minute would be considered as hypofunction. So this is how the collection of saliva is done, either by spitting or by the patient passively drooling into a collection tube. And this is the example of how salivary collector, the Carlson-Crittenden selector appears, which actually has a suction cup or a suction ring, which can collect saliva from the Stenson's duct. These are also examples of a modified Carlson-Crittenden device collecting saliva from the parotid, and these are tubes where the patient can be, the saliva can be collected by asking the patient to drool in or just passively by amount of saliva that's produced at its rate, when the patient is unstimulated. So the samples of saliva can be, packaged in sample collectors and sent off to the lab for analysis. Sialochemistry is analysis or chemical analysis of the contents of saliva.
We must understand that saliva is a complex exocrine secretion containing more than 60 constituents. So, saliva these days is used to monitor viral infections, blood alcohol levels, hormone levels, screening for drug abuse, and even screening for cancer and HIV. And in near future, the oral rapid, which is a salivary test, and we are all aware that it has been vastly used for the COVID-19 pandemic as well, where saliva has been used in all RTK samples to um, identify the presence of organisms or viral organisms. So the oral rapid is a salivary kit which helps in identifying both HIV 1 and 2 in the saliva and is supposed to be quite accurate. So this is an example of the first in-home oral HIV test kit, and similar to the test kits that are available for COVID-19 viral infection. So when we're talking about management of xerostomia, after having an idea about the imaging processes, it must be divided into preventive therapy, symptomatic therapy, local or topical salivary stimulation, systemic salivary stimulation, and therapy directed at the underlying systemic disease. Preventive therapies involve supplemental fluorides, remineralizing solutions, optimal oral hygiene, and non karyogenic diet, which all help in preventing the effects of xerostomia, which is primarily seen on the hard tissue structures, that is, the teeth. And preventive therapies prevent in remineralization of the dentine or the enamel and then prevent caries. Symptomatic treatment, most importantly, is with water. So, after having seen couple of many, in fact, patients who have had xerostomia, they prefer water to any other substitute. So, in fact, to substitute saliva with oral rinses, gels, or mouthwashes, it only can be done to a certain extent, and water seems to be one of the best substitute or the closest to saliva. Saliva, the artificial salivas contain generally lactoperoxidase, glucose oxidase, lysozyme, and lactoferrin, in addition to water itself. They increase the salivary feeling of saliva in the oral cavity and can be used multiple times in a day whenever dryness is experienced. Along with using oral rinses and artificial saliva, increasing humidification and also minimize the caffeine and alcohol intake can help in symptomatic treatment. Topical or local or topical salivary stimulants can be used in cases where there is a residual salivary function left. These help to stimulate salivary flow, and the examples would be sugar-free gums and mints, electric stimulation of the salivary gland, and acupuncture of the salivary gland. Systemic stimulation with the help of secretagogues is done in cases where there is remnant salivary function, and this can be done with mucolytic agents like bromhexine, anethyl triethione, which is a mucolytic, pilocarpine, which is a parasympathomimetic drug. It's a muscarinic cholinergic agonist, and this is generally given in cases for head and neck radiotherapy or in Sjogren's syndrome. It comes with adverse effects like sweating, hot flashes, urinary frequency, diarrhea, and blurred vision. So essentially, all the parasympathomimetic parameters are increased, resulting in excessive body fluids. Cevimeline is also a drug that has been used. It is also a parasympathomimetic agonist. So that brings me to a discussion of a case. This is Mrs. Y, who's a 58-year-old female who reported with a slow-growing, tender bilateral parotid swellings. She reported that of late she's unable to eat spicy food and had to sip water frequently to chew on dry foods. On examination, there was fissured tongue, and the mouth mirror was found to be sticking to the buccal mucosa. No other lesion was seen, and she also complained of occasional red and itchy eyes. Her medical reports were fasting blood sugar was within normal range, it was just 5.4 millimoles per liter. Blood pressure was 130 over 82 and ESR 36. So, if you were asked for the provisional diagnosis, the most important thing that should come to your mind when you're looking at the infection, at the dryness of the oral cavity, along with components of dry eyes, should be Sjogren's syndrome. Also, two investigations that can help you in diagnosis would again be directed towards Sjogren's. And just as an example, writing a referral letter to the physician for further management of the patient. Another case for discussion, 16-year-old previously well girl presented with fever for 2 to 3 days and with a left-sided facial swelling that had arisen within the previous 24 hours. So it's a very short um, history period for a swelling and fever also. She denied any dental problems. On examination, she had an obvious large tender swelling of the left side of the face and she was generally unwell. She had received the MMR vaccination at 13 months of age and then at age 6 and had been vaccinated with the MR in the catch-up program. What is your diagnosis, management, and differential diagnosis? So, this case is that of an acute parotitis or mumps. Mumps is caused by paramyxovirus and it causes fever, headache, malaise, dry mouth, and difficulty in swallowing. May also cause orchitis in older males and rarely pancreatitis or encephalitis. There is no specific treatment and symptoms resolve simultaneously with analgesics, hydrating with fluids, and mouthwashes. So when you look at a case like this, the possible differential diagnosis would be cervical lymph node enlargement due to other reasons, dental infection or abscess because it is in the same area, tuberculosis, and possible lymph node because of tuberculosis involvement, which is also can be seen in isolated tuberculosis, secondary tuberculosis without lung involvement, and strictures or calculi in the parotid duct leading to enlargement of the duct and the gland. So, a note on mumps vaccine is the best way to prevent mumps, and this vaccine is included in the combination measles, mumps, and rubella, and the measles, mumps, rubella, and varicella vaccine. 2 doses of mumps vaccine are 88% effective on preventing the disease, and 1 dose 78% effective. Children should receive the first dose at the age of 12 to 15 months and the second at 4 to 6 years. Adults at higher risk, such as university students, healthcare personnel, international travelers, or where there is a potential mumps breakout, also should get 2 doses. So that brings me to the end of this chapter. I would like you to go back and read through the textbook for further understanding and better understanding. And please feel free to contact me if you still have any doubts. Thank you.